Dr. Wilfly is a professor of psychiatry, pediatrics, medicine, and psychology at Washington University in St. Louis, Missouri. Dr. Wilfly serves as the director of the Weight Management and Eating Disorder Program at Washington University School of Medicine. She has received over $25 million from the National Institutes of Health for the last 2 decades to study the etiology, prevention, and treatment of eating disorders and obesity across the age spectrum. Her work has been influential in establishing the diagnostic and clinical significance of binge eating disorder and in the psychological treatment of BED. Dr. Wilfly's research originated the use of interpersonal psychotherapy for BED. She has served in numerous leadership roles in advocacy and research societies for obesity and eating disorders, and she is president-elect of the Eating Disorders Research Society and clinical care counselor for the Obesity Society, and serves as chair of the Pediatric Obesity Section of TOS.
Because of all this information about binge eating disorder really showing that these are individuals that can be clearly characterized, they have these unique features and impairment, it was recommended that binge eating disorder be recognized as a freestanding diagnosis in the DSM-5. So this is very important for a number of reasons. It really is moving from being in the back of the book as a provisional diagnosis in need of further study, and previously was a specific example of an eating disorder not otherwise specified. And the problem with that is that because the diagnosis wasn't formally recognized, people didn't take the disorder as serious. And because of the association with overweight, oftentimes people thought, no, these are just people who struggle with their weight, and didn't understand that these are people with an eating disorder. So having the diagnosis makes it clear that this is a problem in need of treatment and recognition. So now it's going to move within the DSM-5. This should be out in May. It'll be a standalone diagnosis in the front of the book, and mainly the diagnostic criteria remain the same as what were the provisional diagnostic criteria recommended in 1994, but there is a change in the frequency and duration criteria, and I'd like to review those briefly. So in the DSM-4, the binge eating is a key feature. There are the 3 indicators of loss of control, the marked distress regarding the binge eating, and the frequency on average is 2 days a week for 6 months. In the DSM-5, the features are the same, and the only difference is a frequency criterion that on average it's only once a week, and the duration criterion also changed, so instead of 6 months, it's now 3 months. And one of the nice things about changing it to a more liberal criterion is it allows us to catch these cases earlier, and it also aligns now with the diagnosis of bulimia nervosa that was always for 3 months, but is also moving from having to have binge eating symptoms twice a week to once a week as well. So why do we care about the inclusion of binge eating disorder in DSM-5? Well, there's a number of reasons. It allows binge eating disorder criteria to be reliably applied to clinical cases, so it allows for communication. It also helps reduce the EDNOS category without creating a substantial number of new psychiatric cases, which is one of the big worries in trying to make decisions about inclusion in the DSM-5. So that worked out very well. So it made the group of individuals on the work group much more likely to be willing to align with having binge eating disorder included. Also, it increases access to care through recognition of the disorder among individuals and providers and payers by having this common language and metric. And it will also strengthen efforts to deliver evidence-based care and improve systems of care now that we have a recognized syndrome.